Το θέμα που θα ασχοληθούμε είναι διατήρηση γονιμότητας. Και είπαμε να επικεντρωθούμε, γιατί η διατήρηση γονιμότητας είναι ένα θέμα που με ενδιαφέρει πάρα πολύ τα τελευταία χρόνια. Και απλώνεται βέβαια σε όλο το φάσμα των ηλικιών, αν θέλετε. Αφορά όλα τα άτομα που επιθυμούν να διατηρήσουν τη γονιμότητά τους ανεξαρτήτως ηλικίας, αλλά θα επικεντρωθούμε λίγο περισσότερο τώρα στους εφήβους. Υπάρχει βέβαια το αντίστοιχο ζήτημα και στα παιδιά, όπως υπάρχει και σε μεγαλύτερες γυναίκες που διαγιγνώσκονται με καρκίνο πριν ολοκληρώσουν την οικογένειά τους, αλλά εν προκειμένου θα μιλήσουμε, για να είμαστε μέσα στο θέμα μας, για τους εφήβους. Και όταν μιλάμε για fertility, διατήρηση της γονιμότητας, μας ενδιαφέρει προφανώς η διατήρηση των αναπαραγωγικών οργάνων, και όταν μιλάμε για αγόρια προφανώς μιλάμε για τους όρχεις, για γυναίκες είναι οι οθήκες και η μήτρα. Όσον αφορά συνήθως καρκίνους που αφορούν το αναπαραγωγικό σύστημα, και μας ενδιαφέρει επίσης και η διατήρηση των γαμετών, όπως είναι τα οάρια στις γυναίκες και τα σπερματοζώα στα αγόρια. Και οι λόγοι για να συζητήσουμε, αν θέλετε, διατήρηση γονιμότητας, κυρίως είναι όταν ένα νέο άτομο, ένας έφηβος ή μία έφηβη διαγιγνώσκεται με μια κακοήθεια και θα πρέπει να λάβει μια θεραπεία που είναι δυνητικώς γοναδοτοξική, όταν θα πρέπει να πάρει χημειοθεραπεία, να πάρει ακτινοβολία. Όταν υπάρχουν διάφορες γενετικές καταστάσεις οι οποίες οδηγούν ειδικά στα νέα κορίτσια σε πρόωρη οθικική ανεπάρκεια, ή νόση του μεταβολισμού, σύνδρομο Τέρνερ, μοσαϊκά σύνδρομο Τέρνερ, τα οποία ξέρουμε ότι αυτά τα άτομα αργότερα θα κάνουν πρώιμη οθικική ανεπάρκεια, θα πρέπει να φροντίσουμε για την αναπαραγωγή τους και να ενημερωθούν γι' αυτό. Και υπάρχει και ένας τρίτος λόγος, που θα τον αφήσω σαν μυστικό στο τέλος, που θα το συζητήσουμε. Είναι ένας λόγος ο οποίος προέκυψε τα τελευταία, αν θέλετε, 3 με 4 χρόνια, αλλά θα τον δείτε μπροστά μας ακόμα περισσότερο και περισσότερο, και το αφήνω σαν kinder έκπληξη στο τέλος. Υπάρχει ο όρος oncoffertility, και η έννοια του oncoffertility ουσιαστικά αφορά, είναι ένας όρος ο οποίος εμφανίστηκε το 2006 και τον χρησιμοποίησε πρώτη η Τερέζα Γκούντροφ σε ένα Oncofertility Consortium, αυτή έδωσε τον τίτλο, και ουσιαστικά εννοεί την διαδικασία όπου οι ογκολόγοι έρχονται σε επαφή με τους γυναικολόγους αναπαραγωγής, με τους ανθρώπους που έρχονται με αναπαραγωγή, με ποιο σκεπτικό? Με το σκεπτικό ότι ένα 10% των ατόμων που διαγιγνώσκονται με καρκίνο, τουλάχιστον στις ΗΠΑ, είναι νεότερα από την ηλικία των 40, και αυτό εν προκειμένου αφορά περίπου 135.000 άτομα στις ΗΠΑ, και σε αυτές τις ηλικίες πολλά από αυτά τα άτομα δεν έχουν ολοκληρώσει την οικογένειά τους και ενδιαφέρονται για διατήρηση της γονιμότητάς τους. Και αυτό είναι ουσιαστικά η έννοια του oncofertility. Εμείς είχαμε τη χαρά ήδη από το 2015 να δημιουργήσουμε την Ελληνική Εταιρεία Διατήρησης Αναπαραγωγής, η οποία είναι μια εταιρεία που έχει σκοπό να φέρει κοντά γυναικολόγους αναπαραγωγής με ογκολόγους, και κυρίως μας ενδιαφέρουν οι γυναίκες με καρκίνο του μαστού, μας ενδιαφέρουν τα νέα παιδάκια που διαγνώστηκαν με μορφές καρκίνων, και ευχαριστώ πολύ όλους τους παιδίατρους και τις παιδιατρικές κλινικές για την συνεργασία σε αυτό, και έχουμε μια πολύ εκτεταμένη συνεργασία και με τους αιματολόγους, ογκολόγους και με τους γενικότερα όλους τους παιδιάτρους. Με το που γίνεται η διάγνωση ενός παιδιού με καρκίνο, αυτόματα κινητοποιείται αυτή η διαδικασία, που είναι πολύ σημαντικό, και έχει σκοπό να ενημερώσει για τις δυνατότητες που έχουν αυτά τα παιδιά, και ο λόγος που βρίσκομαι εγώ εδώ πέρα είναι αυτός πρακτικά, να ενημερώσω για τις δυνατότητες που έχουν αυτά τα παιδιά. Αν εσείς τα ξέρετε καλύτερα από μένα, είναι περίπου 76 διαφορετικοί τύποι παιδικού καρκίνου. Αυτοί γκρουπάρονται σε 12 μεγαλύτερες ομάδες. Από αυτές τις ομάδες άλλες είναι πιο συχνές, άλλες λιγότερο συχνές. Από ό,τι καταλαβαίνω, οι λευχαιμίες είναι πολύ συχνές, οι καρκίνοι του κεντρικού νευρικού συστήματος είναι εξαιρετικά συχνοί, τα λεμφώματα, και τα υπόλοιπα είναι λίγο πιο σπάνια. Αυτό όμως που υπάρχει είναι ότι οι παιδίατροι ογκολόγοι έχουν κάνει μια τρομακτική, αν θέλετε, πρόοδο τα τελευταία χρόνια όσον αφορά την επιβίωση αυτών των παιδιών, και δείτε στατιστικά ότι αυτά τα παιδιά ζουν, θα θεραπευτούν από την νόσο τους, και σε δεύτερη φάση θα θέλουν να κάνουν την οικογένειά τους. Άρα είναι πολύ σημαντικό στα πλαίσια της ολιστικής προσέγγισης του ασθενούς να φροντίσουμε όχι μόνο την αντιμετώπιση του οξέως προβλήματος, που είναι προφανώς η κακοήθεια, αλλά και το γενικότερο καλώς έχει το well-being στη συνέχεια. Και κομμάτι αυτού είναι η δημιουργία μιας φυσιολογικής ζωής και μιας οικογένειας. Αν δούμε διάφορους τύπους καρκίνου, Και αυτό αφορά, όπως βλέπετε, ηλικίες, έβαλα 15 με 39. Δεν υπάρχουν στατιστικά που να αφορούν, αν θέλετε, 12 με 19 όσον αφορά τους καρκίνους. Αλλά σε αυτό το κομμάτι είναι πολύ συχνή καρκίνη του μαστού, καρκίνος του θηροειδούς. Καρκίνος του θηροειδούς πάρα πολύ συχνός και σε παιδιά. Φαντάζομαι, τα ξέρετε, τα βλέπουμε καθημερινά. Ακούω από φίλους μου που είναι χειρουργοί θηροειδούς ότι βλέπουν νεότερα και νεότερα άτομα. Ο καρκίνος των όρχεων σε νέα άτομα, σε νέους ενήλικες αλλά και σε εφήβους. Τα μελανόματα. Και σε εφήβους και σε νέα παιδιά είναι τα σαρκώματα είναι πολύ συχνά, όπως το σάρκωμα βοτριοίδες, αν θέλετε, και ό,τι άλλο. Αλλά γενικά υπάρχουν καρκίνοι ακόμα και σε αυτές τις ηλικίες και τουλάχιστον αν δούμε τις στατιστικές από το National Cancer Institute, υπολογίζεται ότι περίπου 80.000 άτομα σε ηλικίες ανάμεσα 15 με 39 διαγιγνώσκονται κάθε χρόνο με κάποιο καρκίνο και αυτό αφορά περίπου το 4% όλων των καρκίνων στις ΗΠΑ. Από την άλλη μεριά, η επιβίωση είναι εξαιρετική και βλέπετε ότι ξεκίνησε κάτω από το 80, πάει στο 85 περίπου της 100 και δεν μπορεί να πάει ακόμα περισσότερο. Και τα τελευταία χρόνια τα πράγματα πάνε, νομίζω, έχουμε τρομακτικές εξέλιξεις στην αντιμετώπιση των καρκίνων όσον αφορά με τις ανεσοθεραπείες, με το individualized medicine, με genetic treatments και όλα αυτά, όπου φαντάζομαι ότι στο μέλλον η θεραπεία του καρκίνου θα είναι ακόμα πιο επιτυχημένη. Πάλι στατιστικές, βλέπετε ότι αν δείτε τις στατιστικές, τις επιβιώσεις, αν θέλετε, στις ηλικίες 0 έως 14 και 15 έως 30 είναι πάνω από 85% και θα πάει ακόμα περισσότερο. Και όταν μιλάμε πρακτικά για διατήρηση γονιμότητας, αν σκεφτούμε πώς είναι η φυσική πορεία της νόσου ενός καρκίνου, έχουμε τη διάγνωση του καρκίνου και από εκεί και έπειτα το δεύτερο βήμα μπορεί να είναι ένα κάποιο χειρουργείο, αν είναι συνήθως καρκίνος συμπαγών οργάνων, και από εκεί και έπειτα μπορεί να ακολουθηθεί χημειοθεραπεία ή ακτινοβολία, η οποία είναι δυνατικά γοναδοτοξική. Καμιά φορά μπορεί να χρειαστεί. I'm sorry for that. So basically, when we're talking about fertility preservation, the process is typically when you have a cancer diagnosis, then you have typically it follows by surgery if it's a solid tumor, and then you have to have chemotherapy or radiation therapy. Sometimes you might have chemotherapy first and then you go back and do your surgery. And this surgery might refer to reproductive organs, and then we have to talk about fertility sparing surgery, or theoretically when somebody has to go through chemotherapy or radiation therapy, then we talk about gonadotoxic therapy. So basically, when you have all this process between diagnosis and treatment, we have to intervene and offer fertility preservation. The earlier, the better. So if we talk about fertility preservation for adolescent boys after puberty, it's a piece of cake. Before puberty, big problem. I mean, we're going to talk about ovarian cryopreservation, but if you look at immature testicular tissue cryopreservation, the results are very disappointing so far. So basically, it's very difficult to preserve fertility in prepubertal boys. But after puberty, it's very easy to collect semen. It's very easy to store the semen. Things are very easy. So I'm going to focus a little bit more on fertility preservation for adolescent girls. And of course, we're all familiar with embryologically with the number of germ cells that exist in the ovary. And unfortunately, every woman is born with a certain specific number of genetic cells. The peak number is around 7 million that happens in utero, and then you have a rapid process of apoptosis, and most of the girls are born with 1.5 million. They enter puberty with 400,000. Out of this, they will use approximately 400 during the reproductive span, and then they go into menopause. And also, if you look a little bit closer in follicular development, this is the classic paper from Claude Mejon. It's kind of interesting, but if you follow a primordial follicle, I just have to remind you, primordial follicle is one oocyte surrounded by a single layer of granulosa cells to a mature follicle that will ovulate. This takes almost 290 days. We think it's 2 weeks. No, it's not 2 weeks. It's 290 days. And through this process, we have a stage that is gonadotropin independent. That means you cannot stimulate the ovaries, no matter what. And this is up to the first, let's say, 200 days. And then after that, you have the appearance of FSH receptors into granulosa cells, and these follicles start becoming gonadotropin dependent. And also, it's important to notice the loss, the apoptosis of these germs, of these genetic cells. I mean, it's incredible how much cells are destroyed through the process of one primordial follicle ending up in a grafting follicle. And you can see here you have the class 1, 24%, class 2, 35%, 50%, 58%, and 77%. Typically, the major loss of genetic cells occurs at the level of class 5 to class 6, and class 5 are these small follicles at approximately 2 millimeters. So basically, you have less than 5% that is preserved from what started in the beginning. So it's incredible how all this fuel of the ovaries is replenished as people grow older and grow older. And the same thing here, you can see this is the development of the follicle. The most important thing is the gonadotropin dependence, which has to do with the appearance of FSH and LH receptors in the granulosa cells. And this actually occurs towards the second stage of maturation. So in young girls before puberty, you have two problems. One, you don't have enough FSH receptors in the follicles. Number two, the pulse generator is not functioning, so you don't have all the secretion of FSH. So there's no way you can stimulate the ovary before puberty to produce eggs. And of course, we have the concept of ovarian reserve. Ovarian reserve is how many follicles are there in the ovaries and how many of these can be stimulated in order to produce mature oocytes. And this is the concept of ovarian reserve, which is dependent on the age, depend on biochemical factors such as basal FSH, basal estradiol, AMH. That's the most important biomarker for ovarian reserve. And of course, you have some imaging to give us an idea if one ovary has enough follicles. Start doing a sonogram on the second day of the cycle. We can see the small follicles, the ones that are over 2 millimeters. And actually, by counting them, we can get an idea of the ovarian reserve. I'm not going to stay into dynamic tests because they're not used anymore. But the most important biomarkers, as I said before, is AMH. And as you can see here, AMH is produced from the primary to the early andral follicle stage, early andral stage follicles, and gives you a more realistic idea of the amount of genetic cells that still exist in the ovary. Therefore, by measuring AMH, you can, number one, measure the reproductive volume, the ovarian reserve, and at the same time, we can measure the damage after treatment, either radiation or chemotherapy. On the other side, sometimes AMH is not completely reliable if we look at women of very young age, because some of these follicles actually do not produce enough AMH, but later on, as these young girls complete their puberty and reach up to the age of 22, 23, they have more of these eggs, therefore the AMH might increase. So a very small AMH in a very young woman is not very reliable in terms of ovarian reserve. And of course, these are the guidelines from the National Comprehensive Cancer Network regarding fertility preservation for young adolescents and young adults. And the most important thing is referral. It's very important to have an early referral for fertility preservation within 24 hours of diagnosis for those people that are interested in pursuing fertility preservation. And that is the main problem, a lack of communication between the oncologist and the reproductive endocrinologist. Because of course, normally the pediatric oncologist is focusing on the problem. This is the life, the danger for the life that has to take care of it. But at the same time, they have to make sure we give all the necessary information for people that they want to desire fertility, and have to give the information about the impact of the treatment on fertility and what can we do to prevent collateral damages. And of course, these are the recommendations that we as a healthcare provider should initiate the discussion. And that is the problem. We don't initiate the discussion for fertility preservation. And that's actually most of the studies have shown, and there's a complaint from most of the parents that nobody told us that this treatment is going to, this treatment is going to cure our child, but eventually might compromise the chance of having a family. And of course, these are all the guidelines from the European Society of Human Embryology and Reproduction, that basically you need a teamwork. You need multidisciplinary approach to the problem. You have to, and very important to have should be a coordinator to communicate between the oncology team and the fertility preserving team. So the patient and the parents do not get totally confused and overwhelmed. So talking about fertility preservation before and after puberty. Before puberty, we have ovarian tissue cryopreservation. That's what we have. After puberty, we have both. We can do ovarian tissue cryopreservation, which is pretty simple, and we discuss about it. And also, the most important thing you can do when we talk about boys, we talk about sperm freezing. Very simple, easy to get. But the difficulties for young girls, oocyte cryopreservation. Ovarian cryopreservation, basically what we do before, when you have a young girl that has not reached puberty yet, we can do a laparoscopy. You can take a piece or the whole ovary, depending on the risk. Depending on the therapy, we can anticipate the risk of total gonadal destruction. And then you can take the cortex, cut it in small pieces, freeze it. The adolescent, the patient will complete the therapy, and then at the later stage, you can take these small pieces, thaw them when she decides to become pregnant, put them back in the same location. That's what is called orthotopic transfer of the ovarian tissue. And apparently it's a quite successful technique. It used to be experimental, not anymore, that can produce offspring. And more than 300 children have been born with this method. So and this is for a nice review from the New England Journal of Medicine. If you have a person that is at risk for ovarian iatrogenic ovarian failure, before treatment, we can take a segment of the ovary, we can get the cortex, and there are two actually possibilities. If you have a condition that there's a risk of having malignant cells in the ovary, apparently you cannot do the autotransplantation. Then, for example, when you have a person with leukemia, leukemic cells have been found in the ovarian tissue, so therefore it's very difficult to argue that you can take pieces of the ovary and you put them back in the patient. So in these cases, what you do, if there's a risk of transferring malignant cells, theoretically you can dissect in the lab early follicles, and you can use what is called artificial ovaries, a scaffold that you can use, and you can have in vitro follicular growth. And if you ask me, this will be the future. That will be the only thing I will be talking in the future, because you can get very big numbers of follicles by doing that. The other alternative is to get the ovarian pieces of the ovary, freeze them, thaw them, and then at the later stage, transfer them back and hope that they will produce a pregnancy. These are you can see, this is the numbers. Actually, there are more than 300 children that were born after reimplantation of ovarian tissue. So the American Society used to characterize the technique as experimental, not anymore. It's considered standard of care. But the most effective way of preserving fertility in adolescent girls is ovarian oocyte cryopreservation. And in order for you to get eggs, you have to stimulate the ovary. This is the classical stimulation protocol. It's very simple. It takes about 10 days. Typically, it starts on day 3 of the cycle. And what we do, day 3 of the menses, we give gonadotropins, right? And it's important to give gonadotropins because the follicles of these girls have FSH receptors that will respond. So typically, it works the same way that it will work in a young adult that decides to do IVF for other reasons. So we do that. We get the eggs, and then we can obtain the eggs. And we need approximately 10 days of stimulation, starting from the first of your period. But what happens if you have a diagnosis of malignancy in a girl and she doesn't want to wait for her period? What do we do for that? And that's kind of an interesting concept, and we'll discuss about it. So a few years ago, embryo cryopreservation presented the most efficacious method of fertility preservation in women with cancer, but not for teenagers, right? But oocyte cryopreservation is equally successful now as compared to embryo cryopreservation. And the reason for that is vitrification. So vitrification is a new technique. It sounds very scientific, but at the bottom line is rapid freezing. By doing rapid freezing, there's no time for crystals of ice to formulate inside the cytoplasm. And if you remember, the oocyte is the biggest cell we have in our body, and the cytoskeleton is the most important because all the embryonic development is based on the oocyte cytoskeleton. The sperm gives you only the nucleus. It's useless for all the important stuff is they're focused inside the oocyte. So if you were freezing the eggs, that would destroy the cytoskeleton. So by destroying the cytoskeleton, there was no fertilization. If there were fertilization, there was not appropriate alignment in the equatorial axis. So the survival rates of the oocytes were very poor, the fertilization were very poor, the pregnancy rates were very poor. Until this theory of vitrification came over, and basically what it is just taking the egg and putting directly into liquid nitrogen. Directly. And if you remember that the movie Austin Powers, apparently he was cryopreserved back from the 70s, and he was raised back in 99 to save the world from Dr. Evil. And this is the difference between a frozen and a vitrified, just to give you an idea. And if you look at that, if you compare slow freezing with vitrification, the difference is that by doing vitrification, we can use very high levels of cryoprotectants. And by using high levels of cryoprotectants, we prevent the formation of ice crystals and you prevent the damage to the cytoskeleton. Therefore, these eggs, when you thaw them, they look perfectly normal. And they have no crystal formation, no damage to the structure. And just to prove that, there are a lot of studies about that, but just to give you a review, it seems that if you look at the statistics in terms of survival, fertilization, and pregnancy rates, the eggs that were vitrified, the pregnancy rates are fantastic. Actually, probably they are might be even better than the fresh ones, especially for these women that do IVF, because there's better synchronization with the endometrium. So people talk about freezing all or freezing eggs. So right now, as we speak, freezing eggs is equally effective as freezing embryos. And you realize that if we take apart the cancer or any other reason, even for young women that they want to preserve fertility because they don't have the right partner, that is a huge step towards women liberation from compared to the 10 years ago, that a woman, there was no way for her to preserve her fertility. She needed to have sperm. So it's very important, and also has to do a lot of social implications. The second problem was that what we said before. We thought, at least that was our teaching, that we have to start the stimulation on day 2 of the cycle. But there was no study to show any different. But there were some women that said, "Listen, I want you to stimulate me right now. I don't care if it's what day of my cycle it is. This is my last chance. I want to get my therapy in 10 days. I'm in day 10 of my cycle. You have to stimulate me." And that's how it started. And eventually, what happened is that we realized, and that was by accident, that you can stimulate any woman at any time of the cycle and you can get the same number of eggs. And that was a fault, because like the classical teaching that everything starts or on the second day of the cycle, and then you have to stimulate on the second day of the cycle. That's not right. That's not correct, because in the ovary, at certain times you have 2 or 3 or 4 waves of oocytes, and if you hit them with gonadotropins, you can get good eggs. And just to prove you that, this is all the publication is started. Everything started. There was not an experiment. There was not a clinical experiment. It was just a decision of a few women that were diagnosed with breast cancer and said, "Listen, I don't want to wait for my cycle. I want you to stimulate me now, and I don't care what's going to happen." And then we have to revise all our theory behind the stimulation. So right now, if you have a young adolescent who's diagnosed with cancer, you can stimulate her immediately. You don't have to wait, let's say, 3 weeks or 2 weeks for her to start the cycle. And that's very important, especially for hematologic malignancies, that these people have to go through the therapy really fast. This is for, actually, these are the studies from women with breast cancer, but also reflects with anybody with hormone-dependent cancer. In this protocol, because there was a big question whether by stimulating the ovary, if you increase the estrogen, that will have an adverse effect in prognosis, especially if you have a young girl with breast cancer or young woman with breast cancer. The answer is no, But nevertheless, if you are worried about the levels of estrogen, you can use aromatase inhibitors, which is actually a medication that blocks the conversion of androgens to estrogen. Therefore, you can have a stimulation, you can have healthy follicles, you can have good quality eggs with very low estrogens. And actually, there was music to the ears of the oncologists, because you know how you talk about breast cancer and estrogen, it's like it's the big aboo there, and you have to make sure that you don't mention that. So letrozole is the medication that can be incorporated in the stimulation, and you can stimulate a woman with hormone-dependent cancer without elevating estradiol levels. Is there a way to protect the ovaries from radiation and chemotherapy? Apparently, if you think about it, chemotherapy and radiation kills faster what is rapidly multiplying. So basically, you want to make the ovary quiet. And the best way to keep the ovary quiet is by giving GnRH analogs, by suppressing the axis. By suppressing the axis, number one, you reduce the amount of blood flow. Therefore, you reduce the delivery of the chemotherapy to the ovary. Number two, you suppress the multiplication of the granulosa cells. Therefore, you theoretically have decreased damage to the rapidly growing follicles. And as you can see here, there are certain meta-analyses that show that if you use GnRH analogs as a co-treatment with chemotherapy or radiation therapy, theoretically you have decreased damage to the ovaries. So fertility preservation in women with cancer and adolescents with cancer is feasible and successful, number one, because we have vitrification. We have a good method of freezing the eggs. We can start stimulation anytime, so that we don't have to delay our oncological treatment. And of course, for hormone-dependent cancers, you can use aromatase inhibitors that will not increase your estradiol levels. Of course, there are risks and complications. For example, ovarian stimulation can create the ovarian hyperstimulation syndrome, but there's a way of preventing that with a new medication. Of course, there are risks related to the procedure of egg retrieval. It's an intervention. We stick a needle and the ovary sits close to the big vessels, the iliac vessels. There are emotional, psychological problems, the pressure of undergoing fertility preservation or assisted reproduction at a very young age. And of course, we do have very good data on the safety of ovarian stimulation for adults. We have no data on ovarian stimulation on adolescents. We don't have a reason to believe they might be different, but that is the fact that we don't have enough data, big numbers for adolescents that went through stimulation. So ovarian stimulation in adolescents can be beneficial, but there are risks and ethical considerations. There is ongoing research into the long-term effects and improved protocols for adolescent ovarian stimulation. And the most important thing, we need a teamwork. So what's the new thing? So the new thing is in vitro maturation. In vitro maturation either of oocytes or of eggs, for two reasons. Number one, because you can get with a small piece of ovary, you can get much more follicles and much more oocytes that you can get by ovarian tissue. Number two, you can avoid the risk of contamination from malignant cells. For let's say if a young girl is suffering with leukemia, we do know there are leukemic cells in the ovary. You don't want to auto-transplant the cells back after treatment. So if you look at the lab, there are studies, and it's still experimental. There's ways of growing the follicles in vitro. You take the tissue, even after for women that were diagnosed with ovarian cancer, you take the specimen, you microdissect, you get the oocytes, and you mature them in the lab and you freeze them. You can get good numbers, or you can grow follicles. And you can see here, and you can have also activation, because basically what happens when you remove the follicles from the natural environment, they tend to grow and go to apoptosis. So you have to block this process. And there are ways of doing it, molecular mechanisms that can block that. But if you ask me, that will be the future, much easier. And you have to think this. This is the new thing now. Transgenders. Fertility preservation for transgenders. And that was going to be a big issue now, because a lot of, if you look at this review article, it is estimated that approximately 500 women per 100,000, 500 persons out of 100,000 individuals are identified as trans women. Many transgender individuals report recognition of their identity at puberty or sometimes even before puberty, even though the mean presentation is 27 to 32 years. And there's a growing number of patients presenting for gender affirming treatment. And this trend goes younger and younger and younger. So what happens if you have a 16-year-old who decides that she's not a woman, she wants to have an oophorectomy, and she wants to have a reconstructive surgery, but at the same time she wants to have kids with their own genetic material. So, I mean, this sounds like scientific, and I'm not going to go into the ethics behind that. I'm just telling you what you will see it in the future, and there's going to be a big demand. And actually, if you look, we're going in the States, and the legislation, it's interesting that younger and younger kids go into, and then it's kind of funny, especially in the States, all the psychological environment pushes these kids. I know, but the protocol also has the legislation. Yeah, but it's a different in the States, different in Europe, different in every country. So, yeah, it's completely different than in the States. In the States, it's and depends also on the state. Different states have different regulations, so it's a big mess. And as we said, in the United States, 0.7% of individuals aged 13 to 24 identify as transgenders, and these transgenders, they want to have fertility. And the problem is when they have to go through gender-affirming treatments, what you're going to do and how you preserve this fertility. So, of course, there are ethical considerations. Informed consent, adolescents may not have the full capacity to understand the complications of ovarian stimulation and fertility preservation, and that causes even more for people that go through gender transition. Parental involvement, what is the limit? How much the parents can involve into this decision? What can they do about it? And there's a balance between parental guidance and autonomy in making medical decisions. And Professor Jessica is the expert in adolescent autonomy, I suppose, in this. It's very important. Psychological support is very important to counsel the adolescents and their families to address the emotional impact of all this procedure. And as I said before, fertility preservation for non-medical reasons, ethical considerations arise when ovarian stimulation is used for non-medical reasons, such as gender transition. Thank you very much.